Okay, this video is called coronary stent thrombosis, coronary artery stent thrombosis in the heart. You know, the arteries on the outside of the heart are called the epicardial coronary arteries. Those are the big ones. That's the one you know the names of. The left main's the big honking one, bifurcates into the left circumflex, left anterior descending going down the front. To the patient's right side, you have the right coronary artery. Those are your three coronary arteries, okay? Here's the paper, the main paper. I read a couple others. This is the best one. Stent Thrombosis, Guide to Risk Factors and Management by Ombre Flowers from Frontiers in Cardiovascular Medicine, October 2025. So overall, it was a good paper, accurate and concise. I like that. But what was completely stupid about it, there's not a single word about nutrition and diet. The most important thing is not in the paper. Conventional medicine has a silent, unwritten law. You can't talk about nutrition. It's completely stupid. The most important thing is ignored. All this fancy talk, fancy literature reviews and science, but ignoring the most important thing. Everything but the 800-pound gorilla in the room. Stupid. Okay, stent thrombosis can be acute, subacute, late, very late. Okay, subacute and very late are the most common times. Stent thrombosis can, of course, result in a myocardial infarction, a big coronary artery occlusion and myocardial infarction, sudden death, congestive heart failure. There's patient-related risk factors they talk about. The patient being old, advanced age, female, they got smaller coronaries. Smoking cigarettes causes, thick blood, so to speak, and other problems. Excessive alcohol ends up being prothrombotic, diabetogenic. Obesity, refusal or inability to take dual antiplatelet therapy. For example, the patient might have a bleeding complication, then they have to stop the DAPT. Procedural risk factors. You get in there to put a stent. It's kind of tough putting a stent in the coronary arteries. The heart's moving, it's beating. You got to get a good view of it. If you don't expand it fully, that stent will be more prone to thrombose. You might not be able to expand it fully because the artery is heavily calcified. If you looked at coronary artery calcification CTs, tons of these patients have extensive calcification. It's going to make it a lot harder to stent. It's more difficult to bypass into a calcified artery as well. Stent under expansion, malapposition to the wall. They underdilate it so it doesn't stick to the wall enough. Then you got it hanging in the breeze a little bit. That's prothrombotic. A geographic miss. They don't center it accurately on the lesion, on the stenosis. Edge dissection at the edge of the stent. There's a ton of things that can go wrong. They chose a stent that was too small. They didn't get the measurements correct. Undersizing the stent diameter. Overlapping stents, the more of them, the more prothrombotic it is. Thick stent struts, stent fracture of one of the struts. The first generation drug-eluting stents. So there's a lot of stuff that can go wrong in the technical aspects of it. It's technically a challenging procedure to do. Okay. So now here's more potential reasons for stent thrombosis. Okay. So obvious, if you understand what I'm saying here, the best thing to do is be a low-fat vegan so you don't ever get coronary artery disease. So you don't have to deal with all this crap. And most cardiologists, they opt towards plant-based diets and they exercise a lot. If you look at cardiologists, they're some of the most physically fit doctors you'll see. Yeah, there's exceptions to that, but in general, it's true. Because if a lot of them are pretty smart and they know, hey, they don't want to end up on that table. Like McDougall said, I think I heard him say one time he never saw a cardiologist that had a coronary artery stent. Lesions related to risk factors. You can have a bifurcation lesion. Those are tough because then if you block off a bifurcation branch, that branch is at increased risk potentially to thrombose. Chronic total occlusions. Okay, you have to reopen something. That's higher risk. Severe coronary artery calcification, like we talked about a moment ago, for a risk for stent under expansion, increased risk of malapposition, can't get it up tight against the wall. In-stent renosis, neointimal hyperplasia, fibroplasia inside the stent can cause it to stenose and occlude. Neoatherosclerosis growing into the stent can cause it to occlude. Tissue prolapse into the stent from fat from an atherosclerotic plaque. All these bad things can happen. You can see how technically complicated this procedure is. A bleeding problem leading to stopping the dual antiplatelet therapy. Diabetes is just intrinsically prothrombotic. Endothelial dysfunction, prothrombotic, okay. Decreases nitric oxide. It's atherogenic, delays healing. It's bad in numerous ways. A large percentage of the patients, probably the majority of them, have diabetes going for coronary artery stents. Chronic kidney disease, especially with GFR, glomerular filtration rate less than 30. It's prothrombotic. Hypercoagulability for other reasons. If the patient has cancer, they tend to be hypercoagulable. Certain other hematologic disorders are hypercoagulable. But the biggest thing, they don't even mention dietary risk factors, which is incredibly irresponsible, because high-fat diets make the blood more prothrombotic. Low-fiber diets causing leaky gut make the blood more prothrombotic. Being iron overloaded makes the blood more prothrombotic. High dietary sodium makes the blood more prothrombotic, inhibiting endothelial nitric oxide production. Okay, so that's irresponsible to not mention that. That's incompetent. So anyways, what I'm trying to say is a lot of things can go wrong. So you're in a tough spot once you've had stents for many years and you got severe in-stent stenosis, because if it occludes, you're at risk for myocardial infarction. So what are they going to recommend? Like a coronary artery bypass surgery. I'd love to talk to Dr. Esselstyn. He would probably know better than anyone else in the whole world how good is his diet at preventing restenosis of a stent. If you exercise and walk a lot, you can build up collateral circulation. You can see that on a SPECT scan. You can get a hint of it at something like a thallium treadmill stress test to get an idea of, could you tolerate a stent occlusion? If you've built up such wonderful collateral, maybe you can handle it. If you've got a good collateral circulation with, connections in the back of the heart between the right coronary and the circumflex or something, maybe you could handle it better. But, how do you draw the line in making that decision to revascularize or not through open heart surgery? I'm not a cardiologist, so I don't know the exact answer to that question. That's a tough question. And, is the patient going to be 100% reliable in following the diet? So that's a tough one. But you see what I'm saying is, once you start walking yourself down this path of having stents, you're potentially going to end up having more stents or a coronary artery bypass graft surgery. So it's a little bit of a tough decision. Anyways, these are the variables involved, and this is why anybody who understands this talk here, you want to become a low-fat vegan. It's obvious.